Good morning, everyone, and welcome to the New York State Alcohol Policy Summit, Local Action, Statewide Solutions. I'm Karina Escamilla, the Deputy Director of the Latino Religious Leadership Program at the Latino Commission on AIDS. I'm part of the planning committee of this summit. We are so glad to have you with us today. Advocates, policymakers, researchers, community leaders, and public health professionals to create a framework to evidence-based alcohol policy priorities to reduce alcohol-related harm across the New York State. As you know, this summit follows our first meeting at the CUNY Graduate School of Public Health and Health Policy in April 2024, and the 6 virtual discussions that have taken place across the state: Capital Region, Central New York, Hudson Valley, Long Island, New York City, and Western New York. We have gathered an incredible amount of the insight from those meetings, and today we are going to share those findings to guide the work ahead. Before we begin, we want to remind everybody a few housekeeping rules from this summit. In order to be considerate and respectful to everyone attending and presenting today, we ask that you mute yourself if you are not speaking. There will be a designated time for Q&A. We ask that you raise your hand if you have a question. You may submit questions at any time during the sessions using the Q&A text box that is over there. And please do not use transcriptions or recording devices during the meeting. After you have attended the summit, we ask you to respond to our survey to feedback. The survey link is available on the chat and will also be emailed after this meeting. Next slide. Here's a quick overview of the agenda for the day. The first hour, we're going to have the presentations addressing excessive alcohol use in New York State, why policy matters, lessons learned, feedback. In the second hour, we have to see our top 3 recommended priorities. We are going to have a Q&A, the poll, and the breakdown rooms with facilitate discussions. And then we're going to have a recap, report back, and the next steps. Through these next 2 hours, we'll focus on actionable steps to help us reach our shared goal: reducing excessive drinking and related morbidity and mortality across the state. This is an ambitious yet achievable goal, and one that requires all of us. Also, I'd like to take a moment to thank everyone who has worked tirelessly to make this summit possible, particularly the leadership and support of the CUNY Graduate School of Public Health and Health Policy, the New York State Department of Public Health, the New York State Office of Addiction Services and Supports, as well as the dedication and the hard work of the Summit Planning Committee. Your commitment is what has made us today the event a reality. Together, we can make a real difference so that you all being here and for your continued commitment to this important cause. Let's make the most of today's discussion, share our insights, and work toward meaningful solutions. We look forward for a productive and engaging summit. With that, I turn it over to Dr. Heaven Battles to kick off today's program. Thank you, Dr. Heaven.
Great, thank you, Karina. Good morning, everyone. My name is Haven Battles. I'm with the New York State Department of Health, and I oversee our alcohol surveillance and epidemiology program that sits in our Division of Chronic Disease Prevention. I'm going to talk today about some high-level information regarding alcohol use and harms in New York State and some of our strategic planning that we're doing. If you've been to some of these alcohol summit meetings, some of the information will be familiar, but we felt it was important to give this kind of baseline information to the entire group on the call today. So our program sits within the State Department of Health, but is funded by CDC. It's a small grant that we have, and just beginning really our alcohol work in the past 5 years at the department. I want to acknowledge that, of course, our sister agency, the Office of Addiction Services and Supports, has a long-standing alcohol prevention and treatment activities, and we are partnering with them on this work. Our grant established this program, and we are charged with monitoring excessive alcohol use, sharing that data widely, building state and local partnerships, linking data to action, and finally informing alcohol policy, which we'll be talking about today. Next slide. So I'm going to start with just some definitions so we're all on the same page of what I'm presenting today. We are focusing on excessive alcohol use rather than something like alcohol use disorder, because it's a broader behavior that an issue that affects the New York State population. Excessive alcohol use is defined by 4 types of drinking. The first is binge drinking, which for men is 5 or more drinks on one occasion, and for women is 4 or more drinks on one occasion. These definitions come from our current dietary guidelines. For heavy drinking, for men is 15 or more drinks on average in a week, and for women is 8 or more drinks in a week. And then it also includes any underage drinking under the age of 21 and any drinking by pregnant people. Next slide. When we talk about drinks, these are the definitions of drinks that are being used to kind of make up excessive alcohol use, binge and heavy drinking. 12 ounces of beer, 8 ounces of malt liquor, 5 ounces of wine, or 1.5 ounces of distilled spirits. These all constitute a single serving. But as you know, we may know, when you order a drink or buy a drink from the grocery store or the liquor store, you may get a serving, what looks like a serving, but it's actually more ounces than this. So some of our data could be underestimates because of those definitional differences. Next page. Okay, great. So we focus on excessive alcohol use here because it is a substantial public health issue in New York State. It's responsible for over 8,000 deaths per year in the state. Nearly 1 in 5 adult New Yorkers report excessive alcohol use in the form of either binge or heavy drinking. It can cause a host of health consequences, both short-term and long-term, including injuries, violence, and chronic disease. It costs the state, the last time this was measured in 2010, $16 billion in preventable costs, and that has increased with inflation over time, those costs. Alcohol-related harms disproportionately impact under-resourced areas and people living in them. And so these are all the reasons that we focus on excessive alcohol use. So I will start first with talking about underage drinking and related harms. In New York, 1 in 7 New York youth initiate drinking early, and that is before the age of 13. So we're close to the national statistic here. We're about 14% of New York youth report drinking before age 13 versus 15% in the country. And this is important because people who start early are at higher risk for developing alcohol use disorder later in life. And I've included an example from a study that among adults who began drinking before the age 15, about 3.5 times more likely to report having an alcohol use disorder in the past year than those who waited until age 21 or later to start drinking. Alcohol is a widely used substance among New York State youth. So again, 1 in 5 high school students drank at least 1 drink during the past 30 days. This is from our statewide youth risk behavior survey. And 1 in 10 reported binge drinking in the past 30 days. Underage drinking can cause both immediate and chronic health effects for youth. Over 100 New Yorkers under the age of 21 die due to alcohol use each year. This includes deaths from causes like motor vehicle crashes, homicides, alcohol poisoning, and suicides. It impairs judgment and can increase the risk of physical and sexual assault among youth, and it can interfere with normal brain development. Okay, I'm going to move to talking about drinking among adults and the harms that adults experience. So about 1 in 5 adults also report excessive alcohol use in the form of either binge or heavy drinking. And you can see the stats, about 16.6% report binge drinking, and this is in the past month, and 6.1% report heavy drinking. This is from our Behavioral Risk Factor Surveillance System 2022 data. Adults who are more likely to report binge or heavy drinking include males, those who identify as white, non-Hispanic, or Hispanic, younger adults ages 18 to 34, those with higher educational attainment, those with higher annual household income, people reporting frequent mental distress, and adults who currently smoke. So among the 2 million New York State adults who report binge drinking, 25% do so at least 4 times per month, and 25% report consuming at least 7 drinks per occasion. And I report this because the risk of alcohol-related harms increases with the amount of alcohol one drinks. So it's important to kind of keep track of that data as well. But I also want to acknowledge that for some conditions like cancer, the risk increases even at very low levels of consumption. And we'll hear a little bit more about that recent Surgeon General's report on alcohol and cancer when Dr. Haley speaks next. Next slide. Okay. I do want to acknowledge again that under-resourced communities experience greater harms related to excessive alcohol use, despite often reporting lower alcohol use rates. So these greater harms include a higher prevalence of alcohol-related diseases, including heart disease and hypertension, as well as short-term health effects like injury and violence. And some of the reasons for why the harms may be higher in under-resourced communities is disproportionately greater exposure to alcohol marketing and alcohol retail environments, the collective impact of stress, stigma, and discrimination, and inadequate access to substance use disorder treatment programs. Every 3 years, we're able to collect data at the county level from our surveillance system. And in 2021, this is data from 2021 showing binge drinking rates by county, with the counties broken out into equal thirds, with the darkest color reflecting the highest binge drinking rates and the lightest color reflecting the lowest, with the middle color reflecting the middle rate. So the statewide rate in 2021 was 14.9% binge drinking, and the county rates range from 8% to 22%. And I'm going to drop in the chat a link to our surveillance page where you can look more closely at these data if you'd like to. Next slide. Okay, and this is the similar map for heavy drinking, where the lightest color represents the third of counties with the lowest rates, and the darkest color represents the third of counties with the highest rates. Statewide rate was 5.5%, with counties ranging from 2 to 12.5%. I include this slide to show the types of deaths that we are seeing from attributable to alcohol use. Oftentimes, folks think of alcohol use in car accidents, some of those more short-term effects having to do with intoxication, and we do see quite a few deaths, over 2,500 related to those causes. We also see 5,500 deaths related to chronic causes, which can be cancer, liver disease, pancreatitis, a number of chronic conditions associated with alcohol use. So this is another reason to focus on excessive alcohol use, because it really is related to a wide swath of health harms. This slide is here to kind of illustrate that alcohol is still our most widely used of our legal substances in New York. So 20% of youth use alcohol and 18% of adults binge or heavy drink. And this is higher than the rates we see for smoking cigarettes, vaping tobacco products, or using cannabis. But the point of including this slide is that it's really an under-resourced area. We don't see as many resources dedicated to alcohol prevention as we do to some of these other substances. Next slide. So we conduct a survey annually that asks New York State adults their opinions on various public health issues and public health policies. And this slide illustrates how serious New Yorkers believe various public health issues to be. The lightest color here on the left is kind of the topic included in the survey that had the most endorsement for being a serious or very serious public health problem. So that's prescription opioid misuse. And then moving across the chart, we can see that 89% think heroin use is a serious problem, 83% think smoking, tobacco use, 85% tobacco vaping, and then 81% of adults believe that alcohol use is a serious or very serious public health problem. So that's a lot of adults, and that's actually up from last year. So we have kind of a large support group of New Yorkers to work with when we try to advocate and educate about the need for alcohol policy. Next slide. And then we were actually able to ask about specific alcohol policies. So the bars in this chart, the yellow bars, reflect support for various alcohol policy solutions. Again, when Sean reviews the Surgeon General's report, we'll hear that one of the recommendations was to require additional health labels. 72% of New Yorkers support requiring additional health warnings on alcohol containers. 50% support banning outdoor advertising of alcohol. These next three have a very strong evidence base behind them. So 46% support increasing the sales tax on alcohol products. 46% support limiting the days and hours that alcohol can be sold. 35% support decreasing the number of stores that sell alcohol products. And then a new topic to our survey this year was 38% support ending home delivery of alcohol. So while not all of these fall above the majority, we do have, a large number of people in New York who would support these policies and some very clear work to do to move these numbers up. Next slide. All right, I wanted to talk just briefly about how the New York State Department of Health is integrating excessive alcohol use into its strategic planning. The first plan I'll mention is our state comprehensive cancer control program. This is put together by our Comprehensive Cancer Control Program and the New York State Cancer Consortium. And the third iteration of the plan, which ran from 2018 to 2023, is when alcohol became highlighted. So what is it? The cancer plan is a cancer prevention and control roadmap with priority areas, measurable objective, and suggestive strategies to reduce the cancer burden in New York State. And it's important because it serves as a guide for community members, policymakers, advocates, healthcare professionals, and others to use as they engage in efforts in their local communities across the state. Next slide. So I included here what the objectives are related to alcohol in the cancer control plan. For adults, it addresses both binge and heavy drinking reductions by at least 10%. And for adolescents, it addresses use of any alcohol in the past month, trying to reduce that by 10%. And there are several strategies laid out in the plan that the different organizations and different sectors can work on, which include educating the public and youth on cancer risk, campus safety programs, electronic screening and brief intervention, encouraging community coalitions to work on the topic, and limiting alcohol advertisement, and also supporting the enforcement of laws prohibiting alcohol sales to minors. So quite a number of strategies are listed in this plan. We are currently in the process of finalizing the next plan, which is under review and should probably continue to list alcohol as a priority area. Next slide. Okay, last but not least is our statewide health improvement plan, which is called the New York State Prevention Agenda. This is aimed at improving the health status of New Yorkers and reducing health disparities through a strong emphasis on prevention. It outlines key health priority areas and how they'll be addressed to improve the health and well-being of New Yorkers. And like the cancer control plan, it's a tool for all local public health agencies, hospitals, government agencies, community-based organizations, healthcare providers, advocates, educators, policymakers, and other partners to promote action, maximize resources, and prioritize strategies that advance health. Alcohol has been in the prevention agenda since 2008. I've listed here the 2019 through 2024 objectives, which again focus on adult binge drinking. The 2019 through 2024 plan had a specific focus on aging. And so we also have an objective about binge drinking among older adults, and then an objective about any drinking among adolescents. We are currently in the process of finalizing the 25 through 29 plan, and will continue to include measurable objectives and strategies for action related to alcohol. Next slide. This is a little preview of the domains and the priorities in the next prevention agenda. In the past, the prevention agendas have been focused around health areas, either conditions or risk factors. This time, the prevention agenda is focused around social drivers of health. So there are 5 domains: economic stability, social and community context, neighborhood and built environment, healthcare access and quality, and education access and quality. And alcohol falls up in the social and community context section. New York will be hearing more about the plan. It should be coming out in the first quarter of 2025. Next slide. All right, so from the State Department of Health perspective, what is still needed? We have this small epi and data program. We have a great partnership with the Office of Addiction Services and Supports that has broad funding for substance use and misuse. We have statewide strategies, but what we're lacking is a comprehensive public health program specifically to prevent excessive alcohol use and its associated harms. And that program, would work in partnership across agencies and could fund communities throughout the state to help address alcohol use at a population level. All right, that is the end of my presentation. We can be reached at alcoholdata@healthnewyork.gov, which I'll also drop in the chat. And I am going to turn this now over to Dr. Sean Haley. Thank you.
Dr. Battles, what a terrific presentation. Thank you very much. Really informative and outstanding, as usual, Haven. So thank you. So good morning, everyone. My name is Sean Haley. I'm an associate professor in the Department of Health Policy and Management at the CUNY Graduate School of Public Health and Health Policy. And this morning, I'm here to talk to you about why alcohol policy is so important. Terrific. Thank you. Many of you may have heard about the federal reports that have been released in recent weeks related to alcohol and health. There've been quite a few reports, actually. The first report was released in December. It was titled "The Review of Evidence on Alcohol and Health." It was released by the National Academies of Science, Engineering, and Medicine. The National Academies is a nonprofit organization. They are not a government entity. And you may have heard about this report over a year ago. Indeed, there was a series of articles from the New York Times that identified relationships between scientific researchers that were appointed to the panel and their connection to industry. Again, that report came out in December 2024. It was followed at the very beginning of this month with the Surgeon General's report on alcohol and cancer risk. And just a week ago, the Interagency Coordinating Committee of the Prevention of Underage Drinking released its report, its draft report, on the scientific findings of alcohol intake and health study. And of course, this report is open for public comment. So the Interagency Coordinating Committee, this is a mouthful, on the prevention of underage drinking, is a scientific committee that falls under the STOP Act. Now, many of you may be familiar with the STOP Act. The STOP Act is a federal act that supports states to reduce underage drinking. Now, there is a lot of information in these reports. They are scientific reports. They are super dense, and I will share with you that I've had to read them multiple times, and I am in no way going to try and drill down to the methodology of these reports. It is super complicated, but what I thought would be helpful for today was to review at a 10,000-foot level the major findings. And to be clear, these reports really focus on what is termed moderate drinking. And you might ask, well, what's moderate drinking? Well, that is drinking that does not exceed the United States dietary guidelines. And those guidelines differ for men and for women. So the guidelines for women is no more than 1 drink per day. The guidelines for men is no more than 2 drinks per day. There has been some pressure in the past to reduce those limits, but that conversation is for another time. So that is a definition of moderate drinking. Now, to be clear, in the review of these studies, not all of the individuals drank at that level. That was the top threshold. Many of the individuals who participated drank at lower levels, and they were compared to individuals who did not drink. I promise you that's just about as technical as I'm going to get. All right, so if you follow me on this slide, on the left we have disease, and we have disease categories. ICPID is that scientific STOP Act committee of scientists. That is a committee that was not, did not have the New York Times following them. The NASEM report, the National Academy of Science, Engineering, Medicine, that is the nonprofit-led committee, and that did have some queries by the New York Times. And finally, our Surgeon General released his report. So we go across, we see that ICPID identifies higher risk of mortality from moderate drinking compared to those who do not drink. And then when we get to cancer, there's some pretty clear consistency between the ICPID report and the Surgeon General's report, especially related to esophageal, oral, liver, and breast cancer. For the NASEM report and the Surgeon General's report, higher rates of mortality for colorectal cancer. ICPID did not look at either pharyngeal or colorectal. When we look at cardiovascular health, we see that ICPID suggests that there may be lower rates, and NASEM and ICPID find lower rates for stroke. I'm going to jump to injury, and we see that ICPID, not quite done, thank you. ICPID, we see higher rates, and then when we look at all-cause mortality, we really see a contradiction. And what I'd like to do is just spend a moment on this contradiction, because I think it helps to explain why one report may have one finding in one area and another report may not have a similar finding. So in this instance of all-cause mortality, ICPID defined it differently than NASEM. ICPID defined it as all-cause mortality that could be reasonably associated with alcohol. So they looked to the literature and said, well, what sorts of deaths do we know are related to alcohol? We're going to take all deaths from those known relationships, all deaths from those causes, and we're going to look just at those. NASEM said, we're going to look at all deaths. All, like, from lightning strikes to getting hit in the forehead. Well, I don't know why I'm saying this, hit in the forehead with a golf ball, like all deaths. So, which may explain why there is a difference here related to relationship between moderate alcohol use and all-cause mortality, with ICPID finding a higher risk of death and NASEM finding a lower risk of death. Next slide, please. Great. So why do these results differ? Sometimes they've begun to get it. Sometimes there are methodological differences between study years and selection criteria. Great. There's strength to some of the underlying studies. For example, we don't have randomized control studies that we can pull from. We cannot randomly select individuals and ask them to drink on a daily basis. There would be some ethical concerns there. I've also already referenced the questions of conflict of interest that came up related to the NASEM report. And finally, I think there's one more, great. We know, however, that these findings are starting to coalesce, especially around alcohol and cancer. Great. So what are the three big takeaways from across studies? First and foremost, alcohol is not healthy. It is not a vitamin. It is not healthy. Drinking less alcohol is generally better for health. There is no disagreement, as Dr. Battles has suggested, about the relationship between excessive alcohol use, for example, heavy drinking, and harms. And finally, great. So what do we know at the population level? So the three reports really do a dive into the relationship between alcohol and individuals' health, but what do we know at a community level, at a population level? Well, we know that there is strong evidence of greater alcohol availability. The more alcohol that's available is associated with greater harms, including greater harms to physical health, alcohol use disorder, violence, crime, and so on. We also know that there are evidence-based alcohol policies that can reduce excessive alcohol use and promote healthier communities. So how do we support those communities to reduce alcohol-related harms? Well, one solution, one proven solution, is to focus on upstream policy interventions. So some of you may be familiar with this slide, and some of you will know how much I adore this slide. This slide is a graphic illustration of upstream, midstream, and downstream approaches and policy approaches to prevent disease and injury. At the very upstream, where we focus is preventing bad things from happening, right? We do that by focusing on laws, policies, and trying to support communities to be as healthy as they can be. Further down, we're looking at midstream, and this is at that point where things are starting to happen, where disease is starting to occur, where injuries are starting to happen. And this is where we begin to intervene, where we're trying to reduce the number of cases of disease, the number of injuries, and to stop the progression of either the disease or injuries from getting worse. This is where we focus on interventions like screening for skin cancer and creating food banks, those sorts of things. Finally, our downstream approach is when disease or injury has already set in, where there's a diagnosis and we have to intervene. And most often at that level, those interventions are medical interventions. And it's where we begin to really focus on our healthcare system and providing clinical care. Thank you. Again, we're really focusing for this conversation and in the development of this framework on a policy approach. So if we're going to focus on a policy approach, what evidence do we have that policies work? Well, turns out we've got a lot of evidence. And that evidence comes from the Community Preventative Services Task Force, more adroitly known as the Community Guide. And the Community Guide has identified a number of policies, a number of strategies that have proven effectiveness. I'll start at the top. We know that increasing alcohol taxes, by increasing the cost of something, people use less. When people use less, of course, there are fewer harms. As Haven suggested, we also know that there's a relationship between alcohol outlet density, especially in urban areas, the relationship to violence and crime, alcohol use disorders, and other problems. We know that when we limit the days and hours of alcohol sale, even by a couple of hours, there's an influence on and a reduction of excessive alcohol use. Commercial host liability built on this legal principle is if you contribute to the harm of another person, you're liable. So what commercial host liability says is if you serve someone that is obviously intoxicated, or if you overserve someone and they get into a crash and injure someone else, for example, you may be liable. We also know that enforcing laws to prohibit the sales of minors is effective. We were in our first summit, Commissioner Fan from the State Liquor Authority said, if I'm remembering this correctly, that the State Liquor Authority had just over 30 law enforcement agents. That's 30 for tens of thousands of outlets across the state. That is clearly not sufficient. No. The electronic screening and brief intervention is effective to reduce harmful alcohol use. It's often administered in primary care. Many of us may have been asked questions related to alcohol use. And last, but certainly not least, we know that community interventions involving coalitions or partnerships within community to prevent use are effective. We have some challenges in New York State. First and foremost, New York State is a preemption state. What that means is that at the state level, the State Liquor Authority is the entity, the regulatory entity granted the authority to grant liquor licenses, either for on-premise restaurants, bars, or off-premise liquor stores, grocery stores, what have you. And that authority resides within that State Liquor Authority. Communities can weigh in, but their decisions and recommendations are not binding. Second, we know that since the pandemic, there have been a host of changes to long-established alcohol laws. Many of those laws were designed and intended to reduce harms, to reduce excessive drinking, or to safeguard against monopoly interest. So I thought I'd give you an example of some of the laws that have been changed in recent years. In 2023, beer was allowed for retail sale on Sundays. In 2023, there was also an expansion of the hours of operation for liquor and wine stores. They were allowed to open earlier on Sundays, Sunday mornings. In 2024, there was the extension of the alcohol to go sales through 2030. There's also a reduction in the requirement to notify communities in terms of the amount of time that requirement was reduced. And there was an expansion. So one-day special event licenses were extended to liquor. Previously, they had been limited to wine and beer. Later in that year, in August, a law was signed that allows direct-to-consumer shipping for up to 36 cases per resident. So you don't have to go to the liquor store. You can just have 36 cases shipped to home. In October, the law was changed to allow businesses to sell alcohol while their full application was pending. So they will be operating on a temporary license. In addition, it doubled the amount of time that license could be legitimate, could be operational at no additional cost. 2025, we don't know yet. We will see what else will change. So you may ask, but wait. New York State gets a lot of tax revenue from alcohol, right? Well, I will let you be the judge. We know that in New York State, beer tax has not increased since 1977. Our wine tax hasn't increased since '83. Taxes only cover about 8% of the total cost of excessive drinking. This is according to Blanchett et al. In their article in 2019. We have the 14th lowest beer tax and the 4th lowest wine tax in the country. Next slide, please. So, and oh, by the way, everything that there are citations in the slides, and we'll make the slides available. So all of that information will be available to you. But in 2023, the revenue from New York State alcohol tax was about $282 million. The cost to New York State government, again, this is based on an article that was led by Sachs on using 2010 data. I've used the Department of Labor inflation calculator to adjust it to 2023 dollars. The cost to New York State government, this isn't cost to industry, this isn't cost to individuals, it's just to New York State government. The cost was $12 billion. So, next slide, please. Great. As we've suggested, there's a strong association between an increase in alcohol availability and harms. This is not causal, it's not the only factor, but we know that the more alcohol there that is available, that the number of harms tends to grow. As Dr. Battle suggested, New York reported more than 8,000 deaths related to alcohol between 2020 and 2021. By comparison, the ending in August 2024, the year ending August 2024, there were 3,500 opioid overdose deaths. Now, I want to be really, really clear about something. All preventable deaths are tragic. And I'm not suggesting that one should take precedence over another. All of these causes should be addressed and fully funded. I do not want to be in the business of taking from Peter to pay Paul. I don't. I don't want to suggest that in any way. That said, I think it is worth suggesting that there's an opportunity to reflect on our current alcohol policy in New York State and to raise this question, given all the changes that we've experienced, how many alcohol deaths will New York have in 2025? And with that, I will turn my presentation over to Christine Cavallucci. Christine.
Thank you, Sean. Good morning, everyone. My name is Christine Cavallucci. I'm the Executive Director of ADAP, an OASIS-funded school and community-based prevention program, and I'm also a member of the Alcohol Summit Planning Committee. And in this presentation this morning, I'm going to review what has led us up to this meeting today. I'll provide an overview of the summit that was held last April and the 6 regional alcohol policy planning meetings that took place from October through December of 2024. And many of you here today attended either one or both of those. Also, as a member of the committee, I ask that you check out our website, which lays the path to the alcohol policy framework from the first summit to the regional meetings. And it will also provide a recap of what we discussed today. So please see that link in the chat, I believe. Yes, thank you. Okay, next slide. Let's begin with a brief overview of the first alcohol policy summit. The first summit started with a series of presentations reviewing the data on excessive alcohol use and related harms in New York State, exploring the importance of alcohol policy in mitigating known harms, the importance of local public and community engagement, and a review of the recent changes that Sean just mentioned of the slew of longstanding New York State laws that reduced alcohol-related harms and guarded against monopoly interest. In general, as Sean discussed, those laws greatly expanded alcohol availability across the state. And since greater availability is associated with more harm, the changes create a considerable public health concern for all. Then the summer presentations provided a springboard for the attendees to break into groups to discuss community experiences and what they saw as policy priorities. Next slide. The next 2 slides identify the main policy strategies that Summit 1 participants discussed. So here we'll have the feedback on what are the most effective policy strategies that you heard today during that April session. The first was taxation. Since the 1980s, alcohol taxes have remained the same despite strong support to increase them. It's also been reported that taxation is usually seen as an easy revenue win as well as to curb excessive alcohol use. Limiting alcohol sale hours, participants shared that an effective strategy to this would be implementing restrictions on the hours in which alcohol can be sold. And additionally, evidence also suggests that changing those sale times can reduce negative outcomes, including such things as violence. Regarding alcohol outlet density control, participants discussed reducing the number of stores that sell alcohol. This also included controlling the density of alcohol vendors, which may help reduce excessive use and negative community impacts. Moreover, participants shared introducing time-based restrictions and controlling those cluster of outlets. And we can see some of those have already changed. Next slide. Other policies, then strategies that were identified include community and youth engagement. Participants noted that community-level efforts and campaigns by coalitions are really crucial to build trust and partnerships with the community members on the ground level. Other community-based efforts included involving a youth voice in discussions and also increasing public education to raise awareness about all the alcohol-related harms that both Haven and Sean have shared this morning. Lastly, participants shared the importance of enforcing regulations. These included mandating alcohol training awareness programs, enhancing compliance checks, involving different sectors to create change, a better understanding of the processes of the State Liquor Authority and how communities can have an impact on the local level, which is often a struggle, implementing voluntary server training, and emphasizing the role of media control and public messaging about alcohol. Next slide. So now we'll talk about the feedback from the 6 regional alcohol policy meetings. The feedback from Summit 1 suggested that the information would be important to share with the local communities. You can just go back for one slide, Monica. Thank you. New York State OASIS, the Office of Addiction Services and Supports, supported these 6 regional meetings to share local data related to the excessive alcohol use and related harms within each of the community. Each regional presentation included the county level data on excessive alcohol use, as well as information from the CDC's community guide on effective policies to reduce harm. As with the first summit, we ask attendees to break into different discussion rooms to discuss the alcohol-related harms and New York policy changes, and also to complete a follow-up survey to rank those policy priorities. Next slide. So this graph shows the registration and attendance for each of the regions for the meetings that occurred between October and December. And as you can see, the highest rate of registration was observed in the Western region, but the highest attendance was observed in New York City. In general, as with many virtual events, about half of the registered individuals attended each meeting. Next slide. We sent a follow-up survey to the participants for them to rank their top 3 policy actions and evidence-based strategies. A total of 79 people filled out that survey. And now we'll take a look at what they were asked to rank. This table includes the immediate actions participants were required to rank. These were the actions related to reducing alcohol-related harms. So I'll just go through them now. One of them was to place a moratorium on any New York State law that expands alcohol availability, to create a New York State Public Health and Safety Alcohol Commission, one that's similar, a public health and safety version of the SLA, to establish a statewide alcohol public health program similar to what currently exists for tobacco. Another action was to secure a commitment from a New York-based foundation to educate county and district level elected officials about alcohol-related harms, and to add a public health liaison to the New York State Liquor Authority. The next slide will show you the table that includes the evidence-based policy changes participants were required to rank. These included an increase of alcohol taxes, to make alcohol training programs mandatory for servers and outlets, to restrict alcohol marketing and branding to reduce all youth exposure, especially within already oversaturated BIPOC communities, to reduce alcohol density in residential communities with disproportionate burden, to reduce hours of alcohol availability, to increase the number of alcohol compliance officers, and finally, to lower New York State's legal blood alcohol limit from 0.8 to 0.5. So those were the evidence-based policies people were asked to rank. The ones prior were the action items. And in our next presentation, we'll review the results of those rankings. But at first, we're going to have a short stretch break. So I think it's 1 minute or 2, Sean, was it 2 minutes? 2-minute break. So 9:49 we'll be back at 9:51. So we look forward to having you back. Just take a quick stretch break.
Yeah, please don't go far.
Okay. Good morning. My name is Bonnie Peck. I'm the Director and Project Coordinator of the Glove City Coalition. We are a Year 6 Drug-Free Communities grant recipient from the federal government. And I have been a member of the planning committee for this for the summit. As Christine said, we asked attendees of the regional meetings to rank action items and evidence-based policies separately. The results will create our priorities for an alcohol policy framework for the state of New York. Next slide, please. After the last results were in from the final regional meeting in December, we combined the feedback from the breakout room discussions from Summit 1 and the rankings of policy actions and evidence-based strategies from the regional meetings with a feasibility analysis to create a list of top 3 ranked priorities for immediate action to reduce alcohol-related harms and a list on top 3 priorities of evidence-based policy strategies. So let's go through the top 3 rankings for each.
Bonnie, you got muted.
You are muted. We can't hear you.
Sorry. Have I been muted this whole time?
No. Just when
Okay.
you said
Just now.
that
That was
transition,
odd.
yeah.
Okay, thank you. Where was I? Educate. So the displayed is a list of the top 3 ranked priorities on immediate actions to reduce alcohol-related harms and establish infrastructure. The first ranked priority included establishing a statewide alcohol public health program. What would this look like? It would be similar to what exists currently for tobacco. Fund widespread community education about alcohol's contribution to health. Create stronger alcohol surveillance systems to assess alcohol availability, use, and the related harms across populations, including youth. Conduct a media surveillance to identify patterns of youth exposure and impact. Fund counter-marketing to prevent youth initiation. And finally, support program evaluation to optimize the use of public resources. The second priority is to educate county and district level elected officials about health and economic costs of excessive alcohol use. Many elected officials may not be aware of the harms or the costs of excessive alcohol use in their districts. And finally, secure a commitment from a New York State-based foundation and agencies to reduce excessive alcohol use as a funding priority. As Dr. Haley suggested, relatively few New York State dollars are dedicated to alcohol prevention. Most of the resources that are available are from federal sources, including the Prevention and Treatment Block Grant and the CDC. We are not sure how the new Trump administration will prioritize prevention. Okay, next slide. This slide shows the top 3 ranked priorities by participants on evidence-based policy changes to reduce alcohol-related harms. The first ranked priority included increasing alcohol taxes. Like tobacco, lots of evidence from the US and abroad documents the relationship between higher costs of alcohol and a reduction in alcohol-related harms. New York State alcohol taxes are low, the 4th lowest in the country for wine and 14th for beer. The second ranked priority is to restrict alcohol marketing and branding, prioritizing youth and BIPOC communities that have historically been targeted by marketing strategies. Some strong evidence suggests a robust and some may say causal relationship between young people's exposure to traditional alcohol advertising, such as billboards and magazines, and use of alcohol. There is increasing evidence that young people are highly exposed to alcohol advertising on social media. And finally, the third priority is to make alcohol awareness training programs mandatory for servers and outlets. Training requirements are not mandatory in New York State. Nairi?
Good morning, everyone. Hello. My name is Nairi Smith. I use they, them, theirs pronouns. I'm the coalition manager and coordinator for Canva's Brooklyn Yes Youth Against Substance Misuse Coalition, and I am a member of the Alcohol Summit Planning Committee. Now, we would like to get a sense of your interests as we create a statewide framework for alcohol policy actions for New York State. As we reviewed the ranked priorities, by Bonnie, thank you, Bonnie, we ask that you complete a short Qualtrics questionnaire in which the link can be found in the chat box provided to you by Ira. Thank you so much, Ira. It will ask you for your name, affiliation to choose which priorities resonate most with you. What on this list might you be interested in working on? So that's how you want to go about filling this out. You can choose more than one. So everyone, if you could just take time to click that link in the chat box, we're going to give it about 5-ish minutes or so to fill that out. And at the same time, while you're completing the Qualtrics, we'd like to open the floor to you all to ask any clarifying questions about either the 3 immediate actions or the 3 evidence-based strategies. You can also add questions to the chat. Our entire planning committee is here and ready to answer anything that you send our way and anything we cannot cover in this 5 minutes. We will do a frequently asked question fact sheet that will be shared with all of you via email because we have your emails for your registration to be a part of this summit. So again, everyone, if you could take some time, please click the link in the chat and fill out the Qualtrics. Thank you. I'll see you back in 5 minutes. Send us your questions. So it's 9:58 right now. We will
Neri,
close and review. Yeah?
Neri, do you want to solicit questions while people are filling
Yes,
it
I
out?
do. You know I do. Thank you so much, Dr. Haley.
And I was gonna say, Nairi, in the chat, there is a good question.
I saw that, Bernard,
We'll have to
right?
circle back, but is there anybody who can answer that?
Right. Well, let me read it out loud for all of those so we can understand what we're referring to. So, Bernard O'Brien put in the chat, my understanding is that 10% of drinkers in the US, i.e., the heaviest drinkers, consume roughly 50% of all alcohol consumed. Can we assume that this is also roughly true in New York State? In other words, alcohol industry sales and profits rely heavily on irresponsible drinking, right? So let's see. Dr. Battles already said this is an interesting point. Dr. Battles, do you want to expound on this a little bit more? Not the right word I used. Expand, I mean, on this a little bit more. And Sarah, I see your
Oh.
question. I'll ask that in after Dr. Battles responds.
Yeah, no, very much appreciate the question. I just have to fall on my own sword that I'm less familiar with the statistic and how it plays out in New York. So certainly is worth looking at and thinking about in terms of messaging we might start rolling out as a state. You know, are we focusing on no drinking or less drinking? You know, so I think it really can play into that, and it is something we'll look into. Thanks, Bernard.
Thank you, Dr. Battles. Thank you, Bernard, for posing that question. Sarah Bonk says, does the suggestion of increased taxes include being mindful of zoning opportunities to change where access is? Anyone in the committee want to take that question?
Neri, I can try.
I believe in you.
Thank you. So, Sarah, I would, yeah, I would separate these out, right? I don't. The tax question would, of course, be a legislative question and a governor question to figure out what that increase would be. Would it apply to beer, wine, and spirits, or would they just look to increase 1 or 2 rather than all 3? And then the State Liquor Authority, and I know David's on, so David, help me with this. But the State Liquor Authority has authority over granting licenses. So in terms of how that might play out in a zoning type of way, and whether there is authority within SLA to think about density issues differently. David, if you're still on, is that something you could respond to?
You know, I don't fully understand the question. Can you maybe just say it in a different way for me?
So my understanding is might there be a way to influence license density? So if I'm
For sure, I think that, license density is something that we take into consideration, particularly when community boards are, talking to us and giving us opinions about whether or not we should be granting licenses. I think as you all know, communities know best what the saturation level is like in their neighborhoods, and so we sort of rely on them to let us know, what the balance that they would like to see is.
Right. Hey, David, can I press a little bit?
Of course.
Okay. How often does SLA turn down a license?
I don't have the stat exactly. More often than flat out rejection is stipulations. So reducing hours, reducing the kinds of things that can happen in places. That's where we tend to come down as sort of a compromise between business interests and community interests.
David, thank you as always.
David, did you talk about, sorry, I had stepped out of my office, so I missed the question, but I'm also with the SLA, Jill Clark from the Buffalo office. David, did you also talk about 500-foot law and the hearings that go around that as well?
No, I did not. You should go ahead.
Okay. So just another thing people should be aware of is that within the alcoholic beverage control law is what we call the 500-foot rule, which states that if anyone applying for a license, the population of the municipality has to be 20,000 or more, which applies to most places. But anyone applying for a license that includes liquor has to, if they have more than 3 licensed premises within a 500-foot radius of the premises where they're applying for a license, they have to have a 500-foot hearing. So an administrative law judge independently reviews their application and just, reviews they have to fill out a public interest questionnaire and has to determine if public interest will be served by the granting of the license. So that's just another process that we have in place through the law.
Yeah, and
Thank
to add on to
you.
that,
I'm so sorry. I'm so
It's
sorry,
okay.
David and Jill. I love this conversation that's happening, but we are coming to our time and we want to be honorable of the time because we have a couple more things to do in this summit. I do not want to stop the conversation from going. So if you want to put that thought in the chat so other people can see it, that would be amazing. I also noticed the questions that are flying in the chat. I love the conversations that are brewing and that our committee has been replying to these questions that are there. We also will be taking note of the chat post this meeting, this summit, and any questions that might have gotten lost inside the sauce will also be addressed by the committee and shared later. So please do not feel that you did not get received when you put a question in the chat. I'm seeing it, I'm copying and pasting it, we got you. But it is about to be 10:05, which will be our 5-minute marker. I hope that everyone took the time to fill out the Qualtrics, because the next thing we're about to do is we're going to go into our breakout rooms, everyone. So thank you. Thank you all. It was nice.